No mai, haere mai. Welcome to this module from the New Zealand Dementia Foundation's Dementia Stars Education Series. Dementia Stars is a series of 8 modules covering some of the most common topics that caregivers work with every day when supporting people living with dementia. You are an extremely important part of the network of people who work in dementia care, and we hope you find this course very helpful for your work. Pain is part of our everyday lives. We have many ways of recognising it, identifying what's causing it, and treating it. For people with dementia, pain is often much more of a mystery. It's possible that most older people that you are supporting are experiencing pain. That's kind of shocking, isn't it? Research suggests that at least half of all people living with dementia are experiencing pain. Research also shows that generally people living with dementia feel pain the same way as people with healthy brains. In this module, we look at how to help people living with dementia who are experiencing pain. Dr. Susan G is going to talk us through how we can be more pain aware.
Tēnā koutou, e tipu aki ao ke murahiku. Ko G te whānau. Ko Susan toko ingoa. Ko tēnei taku mihi ngā tangata whenua o te rohi nei. Ka nui te mihi kia koutou. Nō reira, tēnā koutou katoa. I'm Susan G and I'm a dementia researcher and educator. I'm also the liaison officer for the New Zealand Dementia Foundation. I'm delighted to be able to share this session with you because pain is just so important. In this session, we're going to learn a simple reminder about being pain aware when we're supporting people living with dementia. Think ouch. O-U-C-H. Now, if you're supporting older people as a care worker, you'll be familiar with lots of common causes of pain and discomfort, like falls, back pain, arthritis, urinary tract infections, or pressure sores. Honestly, the list could include almost any part of the body. People living with dementia may be even more at risk of some causes of pain. Think about things like issues that might arise from self-care or from falls. What's really devastating to realise is that people living with dementia often get less help with their pain. One study that created a lot of discussion looked at people who were in hospital because they'd fractured their hip. And what they did was they compared people in the ward whose brains were healthy with people who were living with advanced dementia. And even though they had the same injury and they were on the same ward, the people with healthy brains received 3 times more pain medication than the people living with dementia. So what could be going on here? Well, when we're in pain, we can do something about it. So let's imagine a really sore knee. We could treat the pain ourselves. We might take some Panadol, for example. We can work out what might be causing the pain, and then we can think about how we could reduce the problem. So if I think it's a sore muscle, I might put a heat pack on it. If it's swelling up from a fall, I might put some ice on it. If it's a splinter, I might try to remove it, and so on. If we can't resolve the pain, we can go and talk to someone to get help. So we might go to our pharmacy or GP or the emergency department. When people living with dementia are in pain, there can be barriers to all those steps because of the changes in their brain. It might be harder for the person living with dementia to understand what's wrong. It might be harder for them to do the organising involved in working through how to do something about the pain. It might be harder for them to talk to someone. They might not be able to use words to tell us what they're experiencing. So when we're working with people living with dementia, we need to be extra alert and proactive so that we can overcome these barriers. If you're a care worker supporting a person living with dementia in their activities of daily living and you're spending time with them, you're in such a unique position to spot and help pain. You're priceless. To help us remember to be alert to pain, we can think ouch. Observe, understand, communicate, help. Now this is a tool that we've adapted from Royal Wolverhampton NHS Trust. Let's see what this process of ouch might look like in a story that's based on a real-life example.
This is Annie. Annie's a great care worker. But when we first met Annie, she was struggling in her relationship with one of the people she supports, Mrs. Brodie. She talked about Mrs. Brodie in this very raw way.
I can't stand working with this lady. She won't get up. She won't do anything for herself. She doesn't help herself. You know what I mean? I tell her, you've had an x-ray, your hip is fine, you just have to get on and do things. She repeats herself over and over. She's just attention-seeking. Her dementia is getting worse. She's doing my head in. Honestly, I'm in and out as fast as I can.
Annie had the chance to take part in some education about person-centred care. There are 4 simple steps to a person-centred approach to pain. O-U-C-H. Ouch. Observe the person with dementia, looking for changes in their behaviour and mood, and for non-verbal signs of pain. Understand that changes in a person's behaviour may be communicating that they have pain, rather than being because of the dementia itself. Communicate with the multidisciplinary team, including the person with dementia and their family. Help by investigating the cause of the pain and treating appropriately. After the course, we heard Annie's understanding shift, and she ended up saying,
So it's like, I could see it differently. I could see that you know that not wanting to get up and do things was about the pain. For goodness sake, she was trying to tell us that it still hurt. Because she'd had that x-ray, I thought she can't be in pain. She just wants to keep the attention going. But you know, if she's in pain, she is in pain. And that was making her anxious. I told a nurse in the team what I had noticed and asked her advice. We pushed for a CT scan of her pelvis. It was fractured. So her new care plan was about rest and regular meds and lots of reassurance for a while. Now each time I go in, I ask her, what is the one thing I can do for you today that will make a difference? She doesn't repeat herself anymore because we actually listen. And she's doing more for herself too. I'm excited now. I don't feel like my head is being done in. She wasn't attention-seeking. It wasn't her dementia. She wasn't just wasting my time.
be pain aware. Think ouch.
That's quite a dramatic change in how Annie approached things, isn't it? Let's look a bit closer at how we can be pain aware by thinking ouch. We'll go through it in steps. The O in ouch is for observe. That means we're on the lookout for pain. Let's ask, learn about the person, and look and listen. So the first thing we can do is ask. When we're supporting people living with dementia, we're thinking about how to ask about pain in a way that works for them. We want to ask about whether they're experiencing the pain right now, so they don't have to use their memory. If we think that Mr. Patel's knee hurts when we're helping him get dressed, we can stop and ask him there and then. And sometimes it can help to ask the question a couple of times using different words. Sore, hurt, uncomfortable, tender. And we can slow down and allow the person lots of time to answer. We can show we're really listening. So we give them all our attention and make eye contact. Now imagine that I walk past you and I'm doing something on my phone and I ask over my shoulder, "How are you?" and I keep going. Now imagine I crouch down beside you, put a hand on your arm and I look you in the eye and ask really kindly, "How are you?" And I wait for your answer. Same words, but would we get the same answer? I don't think so. Now the second tip on our list is to learn about the person. If we want to tell whether someone's in pain, it's going to help to know what they're like normally. That means getting to know them. You might learn what are signs of pain for that particular person. Our third tip is a big one. We want to look and listen for signs of pain. Now imagine I've got a sore shoulder. Ow! You could pick up cues in my facial expression. I screwed up my face, didn't I? So you might see someone wince or look tense. You could pick up clues in my vocalisation, in the sounds that you heard. So you might hear words and sounds like my ow, or a groan, or a gasp when you're helping them with activities, or the person might be calling out for help. You could pick up clues in my body language. So I held my shoulder, didn't I? You might see someone guarding a part of their body or actually rocking back and forth. And you might pick up clues in changes in behaviour. If you tried to help me take a cardigan off, I might not want you anywhere near my shoulder. And if you asked me to come join you for something exciting that I usually love, like a Dementia Stars education module, I might not feel I'm up to it. I might refuse. And we saw that in Annie's story, didn't we? When Mrs. Brodie stopped doing things for herself. Now, if my shoulder keeps hurting, I might go off my food. I might not be able to sleep. So those are all changes in behaviour. You might also pick up changes in mood. How might I feel if my shoulder keeps hurting day in and day out? I might be grumpy or sad or anxious because I don't understand what's going on. Remember how in Annie's story, Mrs. Brodie became more anxious, and her way of showing that was that she kept asking repeated questions. So, when a person living with dementia is less able to tell us that we're in pain, we need to be more proactive about observing, to pick up pain in facial expressions, in vocalisation, in body language, in behaviour and in mood. So that's our O. The U in ouch is for understand. One of the important things to understand about pain is that pain is personal. Margaret McCaffrey has said that pain is whatever the experiencing person says it is, existing when he or she says it does. And that was one of the things that tripped Annie up in the video, wasn't it? Annie thought that because the first x-ray didn't show a fracture, she knew that Mrs. Brodie wasn't really in pain. We can't make the decision that someone shouldn't be experiencing pain. So, for example, some people may have chronic pain that continues even after the initial problem's gone. We can't judge the situation according to whether we would feel pain. Some people living with dementia become hypersensitive to touch, and helping them get dry by rubbing their skin with a towel may actually hurt them. It wouldn't hurt us. So pain is personal. It's also important that we understand that whenever we see a change in a person living with dementia, we should wonder, could that change be pain? When we're working with people living with dementia, it can be easy to blame the dementia for any changes that we see. We saw that in Annie's story when she blamed the changes in Mrs. Brodie on the dementia getting worse. Here's the thing, if we don't look beyond the dementia, we may not see things that we can help fix. Now, you may hear people talk about behavioural and psychological symptoms of dementia, or behaviours that challenge. I like to call these responsive behaviours, because the person is responding to something bad, frustrating, overwhelming or confusing. We can think of all behaviour as communication. The responsive behaviour is telling us about an unmet need. Our job is to interpret their language of behaviour. One of the things we want to be considering is, could that change in behaviour be telling us that they're in pain? Now, it can be challenging to work out what people are telling us with their behaviour, and that's not just when it's someone living with dementia. Sometimes the best way to tell if our interpretation is right is to see if things improve. We address what we think is causing the pain or distress, and we see if that makes a difference. The C in ouch is for communication. One aspect of communication is that we seek information. Now, particularly when a person finds it harder to talk with us, it can be really useful to get some insight from people who know the individual well. Perhaps you've had a situation where someone who knows you really well picked up that you were upset, but other people didn't even notice. If I were your care worker, they might be a great person for me to talk to. Whānau can be a great resource. Sometimes another co-worker may have worked with the person for longer than you have, and they might have picked up some really useful insights. Now, the other side of communication is that we want to share what we've observed. If you're concerned that you have seen pain in someone that you're working with, talk to clinical staff about those concerns. Describe what you've observed as clearly as you can. What have you noticed? How often does it happen? Does something seem to trigger it? For people who aren't able to communicate verbally, we can record what we observe on a pain scale, like the Abbey pain scale. Now, this is a really common sense way of recording those observations of pain that we were talking about before. Vocalisations, facial expression, change in body language, behaviour change, and if there are any physical signs that we can see. It's a great way to share information about pain and distress. So imagine that you notice that Miss Wainui is grimacing and massaging her hands, and you know she has arthritis. You check and her fingers are warm and red and swollen. Now, before you leave, you give Miss Wainui some of her prescribed Panadol. So how will the next staff member know if Miss Wainui's pain is better or worse? Well, we can use this kind of a scale. Last but not least, the H in ouch is for help. Let's hear from Dr. Matthew Croucher, psychiatrist of old age, and caregiver Honey Mohan about how we can help people who are experiencing pain.
Since I am a carer, I know each and every resident over there, and if there is a slight difference in their behavior or if they are showing any unusual behavior, I really come to notice it really soon. For example, Mrs. R, she had a stomach pain actually, but she was touching the stomach and she was telling, something is wrong with me, but I don't know what is wrong with me. I just want to, I don't know, something is happening inside me. Can you just feel it? And by the way she was talking and by the way she was holding her stomach, I could really understand that she is having a stomach pain or her stomach is upset, and that really helps us to know more about that person, that she is not well, and that's how we inform the nurse, and that's how she gets treated. So it's really important. Since I know that resident nicely and very well, that helped me a lot to know what she is having, and since she could not explain more about it, it really helped me. So it's really important as a carer to understand the person, to know the person and to know what they really want other than me guessing that this is the reason. So I would suggest all the carers that instead of we thinking that this might be the reason, we should really go inside and see the real reason.
So for us as care workers then, I think all this thinking opens up some unexpected doors to help us with pain. I think often what we do is we look for something quick that we can fix. So if there's a pin stuck in my foot or my hand, the obvious thing as a caregiver, can I fix that? Can I put a Band-Aid on? Our next thing that we often think about is a pain medication, and pain medication can be really helpful. But we're ignoring the brain side of it and the environment side of it. We've got a lot that we can contribute to people with pain, even if it's that chronic pain that's going on and on and on for months or even years. We can change the environment to make it less stressful and less intense for a person, and add positive things into that environment, like gentle touching or a massage or nice music or something like that. Plus, we can provide brain-to-brain support, reassurance, comfort, care, a hug. All of these things feel as though they're a waste of time, because surely pain's a bigger problem than that. And yet, can you remember times that someone was able to help you when you were sore by paying attention to you and your feelings, rather than leaping forward with a Band-Aid or Savlon or paracetamol?
One of the take-home messages from Matthew and Honey is that help for pain isn't just medical. We can look for ways to provide comfort, reassurance, relaxation, and distraction. And this can actually help dial back pain. What works best is going to depend on the individual. But we can ask ourselves, is this something this person likes doing that will take their mind off the pain and lift their mood? It might be music or some activity that they really enjoy. Is this something that helps to settle and reassure them? It might be a hug or a familiar person or their routine. It can be really helpful to ask family for these kind of suggestions. Whatever we try, we want to ask, did our help work? So we've identified that our person is in pain. We're following the updated care plan to do all that we can to help reduce the pain and to remove any causes of pain that we can. Is it working? We want to check if our help has reduced the pain. That way, we know whether we need to try something different. Some very general rules of thumb are: check after 60 minutes for medication, check after 30 minutes for comfort measures. Now, we also want to check each shift or visit for at least 24 hours until we're sure the pain has resolved. And remember that for people who can't talk, a pain scale like the Abbey Pain Scale can be really helpful. If the signs of pain haven't improved, then we need to tell our clinical staff. Now that brings us to the end of our journey through pain and dementia. We've used Think Ouch to help us be more pain aware, to observe, understand, communicate and help. Thank you for your support of people living with dementia. Thank you for your time. Thank you for the difference you can make by being pain aware. It's been an absolute pleasure to share this with you, and I do hope that you'll find time to check out the other Dementia Stars topics.
We hope you have found this Dementia Stars course valuable. We really appreciate the time you have taken to allow us to share some new ideas and fresh perspectives on this important topic with you. We hope you will return to your work with people living with dementia with renewed enthusiasm. It's such an important job, and you are a very precious part of the dementia family. The New Zealand Dementia Foundation would like to thank CHT Healthcare Trust for their generous support of this project. If you would like to learn more about the New Zealand Dementia Foundation's work, check out their website and join the community. This module is one of a series of Dementia Stars courses. You can find out more about the other topics from your workplace educator or on the New Zealand Dementia Foundation's website. Ngā mihi mai oha. Thank you so much for your commitment to people living with dementia.